Thank you very much for inviting me. A really pleasure to be here. Do you want to talk about mental health promotion of individuals with Down syndrome? I'd like to leave time for questions at the end. I think we'll probably, if it's okay, have you put them into the chat, and then Amanda can. Uh, some of them will be similar. She can kind of bunch those and whatnot, and we can work with that if that's okay. Um, just quick to introduce myself. I am the medical director of the Advocate Medical Group Adult Down Syndrome Center. We're in Park Ridge, Illinois, which is a Chicago suburb. I like to say if you've flown in the Northeast runway to O'Hare, you flew through the hospital cafeteria. We're pretty close to O'Hare, and the jets go pretty close. This is our building. We're on the campus, and and this is where we see individuals at our place. We opened in 1992 at the request of our local parent group, and we started 2 mornings a month, and it just sort of took off. And we've had the good fortune of seeing over 6,000 adolescents and adults with Down syndrome over the course of time, with over 6,000 patient encounters a year. So it's a busy place with lots of individuals with Down syndrome and their families coming through. This evening, I want to talk about the interaction between physical, mental, and social health. I want to describe some of the common behavioral characteristics of people with Down syndrome. And then I want to identify some common mental health concerns, and then provide some practical strategies to promote mental wellness. Then I want to present a few case examples. Now, certainly what we've learned and what others have learned over the many years cannot be shared in 45 minutes or an hour. And so we do have a lot of information on our resource library, and I'll share an address at the end of the presentation as well, that you can take, and we'll be sharing these slides as well. And so our resource library has the information, I say, divided into 3 columns, if you will. Information for people with Down syndrome, information for families and caregivers, and information for healthcare professionals. Amongst ourselves, we call it the hub, meaning while we do write a lot of the information on our website, if someone else has done something that we think is good, and many people have, we're very happy just to put a link to their information rather than starting from scratch, so that we have links to lots of other people's information on our website as well. And so it's a good place to come and find information. The information for people with Down syndrome to accommodate a broad range of reading skills has pictures or video for all the information, so that even if someone cannot read, they hopefully will find that helpful. And all the videos, all the health education videos for people with Down syndrome, the actors and actresses have Down syndrome, which is not only fun to do, but also we think very beneficial for the individuals watching. So let's start with what is optimal mental health. Mental health includes psychological, emotional, and social well-being. It's the ability to cope and engage with others and handle stress and make positive, healthy choices and find fulfillment and joy in life. And it may look different for every person. And so what one person's mental health is not necessarily the mental health of someone else. So that it's unique for each individual, whether they have Down syndrome or not. Certainly the absence of mental illness or the ability to manage mental illness. So some people with mental illness can be very healthy, mentally healthy, because they have learned to, with treatment or with other means, learn to manage mental illness. And it includes optimal level of functioning for the individual. And so really having a social system and a mental wherewithal that we're able to optimally function the best of our abilities. There are a lot of things that go into mental health and mental illness, so it's really a continuum. There's a lot of things that play into that. We do know that mental illness or behavioral challenges are more common in people with Down syndrome, and there are a number of reasons for that as well. So obviously we start with the genetics. Having the extra 21st chromosome does certainly play into the changes in the frequency of mental illness. But then there are some physical health conditions, many of which are more common in people with Down syndrome. Some are less common, but some are more common. And that certainly can play a role because there's such an intertwining between mental and physical health that can play a role. The brain anatomy of people with Down syndrome can contribute to less than optimal mental health for a variety of reasons based on what the anatomy is. Physical activity is a big contributor to mental health. And so certainly we encourage the individuals we see to be physically healthy, which will also promote their mental health. Recreation and social activities. I don't know how it is in Maryland, but in Illinois at age 22, when people age out of school, finding employment and recreational and social activities that were just part of school is not always easy. And so that can be challenging as well for people. Healthy eating is a very important component of mental health. Foods that help us feel better and to promote our physical as well as our mental health are an important piece of mental wellness. Good sleep, very important. Sleep challenges are more common in people with Down syndrome, sleep apnea and other sleep problems. And all of those can contribute to mental health or mental illness if they're not well managed, if it's not well managed. Stress management. One of the things that is less common in people with Down syndrome is hypertension or high blood pressure. And oftentimes someone will ask, well, is that because people with Down syndrome don't have stress in their life? And I'll say, no, that's not the reason. It's actually probably an issue with the autonomic nervous system, the part of the nervous system we don't think about that's a little different in people with Down syndrome. And so high blood pressure is very uncommon. But certainly people with Down syndrome do have stress. Maybe not, most of our individuals we see are not, trying to figure out how to pay the mortgage, but they do certainly have stress in their lives, and that is something that can be contributing to mental health or mental illness. I like to say that stress is in the eye of the beholder. And so what I find stressful, a person with Down syndrome may not, and what they find stressful, I may not, but that doesn't make my stress any more or less or their stress any more or less. And so that, again, it's in the eye of the beholder, so to speak. Good hydration is important to just how we feel in general, as well as promoting physical and mental health. I'm convinced a lot of people with Down syndrome go through life at least mildly dehydrated based on histories and physical exams and blood work. And so really promoting a good fluid intake is a very important component of mental wellness. And good relationships, having friends and family involved, and certainly a promoter of mental health for all of us. Years ago, pre-cell phone era, we were at a conference with a young woman with Down syndrome, and she was saying how she, if she wanted to do something on a Friday night, she would get out her Rolodex, which the younger people in the crowd here may not remember what that is, but it was like a file with phone numbers in it. And she would just start going through the Rolodex, and she had a significant Rolodex that she would just call people until she found individuals that she would be gathering with that Friday evening. So very important relationships, a very important part of our mental health, and again, not unique to Down syndrome, obviously. And then employment and vocational opportunities, and then are very important as well as in promoting health. And then social media limits. So, clearly lots of information coming out about some of the negative aspects of social media. And certainly people with Down syndrome are not immune to that. And we do see a number of folks that can get, just like any of us can kind of get stuck on flipping through Facebook or whatever, and what the potential negative impacts on mental health can be. So all those things and more can roll in. Communication skills are another important issue, and so lots of issues that can participate or can be part of mental health and mental illness. One of the things that we find that's so important, and we're going to really kind of kick off with, is the interaction of physical, mental, and social health. And again, this is not unique to Down syndrome. This is really true for all of us. And so we certainly see that, these three really do intertwine with each other. I think one of the reasons, particularly with regards to the physical health impact on mental health, that is probably more important in people with Down syndrome in some ways, is because of the communication skills of some individuals. And so they may have a hard time saying verbally that they have this pain or they don't feel well physically for this reason. And so, like any of us, if we're having trouble expressing that discomfort, it may come out in a behavioral change or even a mental illness. Some physical health problems can directly cause mental illness, like a hypothyroidism, an underactive thyroid can directly cause depression. And some things can cause, people just don't feel well, and so that ultimately alters their mood. And again, that's not unique. Any of us, if we don't feel well, may have, may not have the same mental health that we would otherwise, or behaviorally we may change, maybe a little more grumpy if we don't feel well, or whatever the case may be. And again, not unique to Down syndrome, but very common and probably more of an issue because of the communication issue. So in addition to the interaction between physical, mental, and social health, I think another really important thing to understand about mental health in people with Down syndrome is what we call common behavioral characteristics. Now, again, these are not universal to people with Down syndrome. They're not completely unique to people with Down syndrome. Many of us, as you'll see in a moment here, have some of these common behavioral characteristics, but they certainly do play a role in many people with Down syndrome that we interact with. And the first one is self-talk. And this is something we got really interested in 30 plus years ago, even more than that, when the clinic first opened 32 years ago. A lot of the people we were seeing were coming in on antipsychotic medications. And we had read that psychosis was not as common in people with Down syndrome. So we were a little confused by that. How come so many people were coming in on an antipsychotic medication? And as we pieced together the history for these folks, many of them were on the medications because they talked to themselves. And that was assumed to be hallucinatory. And as we began to piece through this, we really felt that this was, for many of our folks, a developmental stage appropriate behavior. By that, I mean, the individuals were developmentally, that was similar to a younger person who self-talk is very common in younger children. And not only self-talk, but imaginary friends. They go kind of hand in hand. And so we really felt that this, for a lot of our folks, where they were developmentally, that this was really similar to where someone else, a child was, who was also at similar developmental age. And so as we began to look at this more, really it was clear that it was a coping strategy. So if people were under stress or there's something bothering them, they could talk it through, just like if I'm driving home at the end of a workday and I'm kind of thinking through my day. Many people with Down syndrome will do the same, but they'll do it out loud. And sometimes, and you'll see in a moment here, some of us talk out loud ourselves. But anyway, the other thing is that another place we see it is boredom. So during the appointment, if the conversation kind of shifts away from the person with Down syndrome, sometimes it moves over to the family, perhaps to talk about a little more complicated medical issue or something. Sometimes I'll see out of the corner of my eye the person with Down syndrome is speaking to themselves, and they're just sort of just sort of filling the time by talking to themselves. So in and of itself, we don't think that self-talk is a sign of mental illness, and we think it's actually a very appropriate thing for most of our individuals, and is a great way to solve problems, to cope through things, and to entertain oneself when they're bored. And in fact, we now know that as research has looked into self-talk more, we now know that athletes tend to talk to themselves, and it's a way of motivation. I joke that I've run the Chicago Marathon several times, and at about mile 23, I can usually be seen self-talking and suggesting to myself that this is the stupidest thing I've ever done in my life. But most athletes will use it more as a motivation rather than the negative. But anyway, and then as further study has gone on, many of us talk to ourselves, but just don't talk about it or don't admit it. And so really, it's actually a common thing. And so definitely not unique to people with Down syndrome. Probably one of the differences is that some folks with Down syndrome don't have the social skills to know when and where it might be appropriate. And so I say that, talking to oneself on the back of a Chicago City bus is probably not the best thing from a social acceptability standpoint, or at least from getting some grief from the other passengers. But in and of itself, again, we don't see this as a mental illness. However, a change in the quality or frequency may be a sign of stress or mental illness. So if someone, typically comes home at the end of the night, or the end of the workday, and goes into the room and kind of talks through their day, And then over the course of time, you notice that the self-talk is becoming more agitated, and they're losing the ability to understand that doing it in the room is okay, but not in the middle of the classroom at school or whatever the case may be. So those changes can be a sign that something's going on, and we want to take a further look into that. Another common characteristic is what we call the groove, and this is a tendency towards sameness or repetition. Again, people, not unique to people with Down syndrome. Many of us get through our day. I say that I tend to put my keys in the same place every night when I get home, so that in the morning when I'm inevitably running late, I know where they are and I can get out the door more quickly. So that's a sign of the groove, or a use of the groove. And many people with Down syndrome do that. They're able to, once they learn something, they can do it very well repetitively. And it can be very functional. When I was a high school student working in the grocery store, back in the days when grocery stores closed in the evening, at the end of the night, the job was to bring all the items on the shelf forward so that they were easier to reach in the morning when the customers came back. I wasn't very good at the job because I would get bored quickly. But many of our patients do this, and they do it very well. Maybe not always the fastest, but they're very precise. And they're very good at this, because once they've learned it, they're able to do it repetitiously very well. So it can be very functional. Sometimes if it goes awry, sometimes people are called stubborn or inflexible. But again, there are ways to work around that. And we have a whole presentation on our website about the groove that you might find interesting. And another thing that's real common in people with Down syndrome is a very strong visual memory. So much greater typically, not always, but typically than auditory memory. So what someone is told, they may not remember or follow the directions as well as something they're shown. And so they can be very good at remembering visual data. And in fact, some people seem to have almost what we call a videographic memory, almost like they can replay the event as if it's happening right now in their mind. And so that can be a very positive thing if it's a positive experience. Unfortunately, it can be a negative thing if it's a traumatic experience that they're remembering. And sometimes the memories can almost be experienced as if they're happening now. And then for some people with Down syndrome, they have a limited sense of time in chronological order. So if they're remembering this, very strongly as if it's happening now, they may actually have some confusion as to when this occurred, or at least as they're describing it, it may be confusing to others when this occurred. And sometimes that gets people in sort of trouble, if you will, in the sense that those around them think that they're making it up, or that they're, misremembering something, but in reality, they're remembering something from the past and almost replaying it as if it's happening now. And so that sometimes can be a little confusing for those people trying to sort out what the person's talking about. The other thing that we see is what we call empathy radar. And this is, again, for a lot of our folks, tend to be very sensitive to the emotions and feelings of others. So in a sense, in some ways, some of our folks are like mirrors. So they really reflect back what's going on around them. They've absorbed that and they reflect that back. And so if there's challenging situations going on around them, they can really absorb that negativity and then reflect that back sometimes. But it can be very, in a very positive way. A young man was at his school, it was a parent-teacher student conference evening, and his parents and he and the teacher were, talking about his schoolwork and whatnot. And the young man suddenly said to the teacher, "How are you doing tonight?" Very heartfelt. "How are you doing?" And the parents are like, "Oh my goodness, he doesn't understand what this is about. What's he talking about?" And then the teacher started to cry, and the parents said, "Oh my goodness, now what has he done?" And the teacher explained that the teacher explained that her good friend from back home, where she was originally from, had passed away, and she was hadn't told anyone because she wasn't sure she could get through the evening if she did that. But she was going to jump on a plane later that evening to go back home. And so, really only the young man with Down syndrome was the only one that really picked up on her grief. And so they talked the rest of the time during the conference about his real sensitivity to others around him. And again, that if it's, it could be a very positive thing. Unfortunately, if there's a lot of negativity around a person, that can be a challenge for that individual. So common behavioral characteristics that can be helpful for health promotion, and we'll talk about the groove. If once you've learned something, you can really do it well. And if with the visual skills, if you make something a visual aid, that can be very helpful to promote healthy behavior. And typically these are not a sign of mental illness, but if there's a change, they can be. And so in and of themselves, so all those people we saw early on in the clinic, the great majority of them were not psychotic. They were just dealing with stress and talking to themselves. So let's shift gears a little bit and talk a little bit about common mental health concerns. So, some of the symptoms we might see with as a mental health change would be a change in behavior, which again can be a form of communication. Again, so if someone has a physical health issue and they're not able to say what it is, that change in behavior may be a form of communication of what they're trying to share with us. There can be a change in the self-talk, or change in the groove, a change in sleep patterns, a change in weight, restlessness, irritability, loss of interest in activities, something someone previously enjoyed, now they don't enjoy doing it all. Fatigue, inappropriate fears or avoidance of people and things, and sometimes a strong refusal to leave home. It can all be symptoms of a mental health problem, mental illness. So starting with a good history and physical exam are important when evaluating for change in mental health. And I'm not going to go through all this slide. This is actually a very short list of the possibilities, but this is just kind of give you a sense that there are many medical conditions that can contribute to a change in behavior or a change in mental health. And so it really does behoove us to in a sense, be detectives, kind of really look for these things. What's going on that might be contributing to this change in mental health or behavior. And the other thing we know that in diagnosing mental illness, in the non-intellectual disability world, there's a book called the DSM-5 Revised, and that's sort of it's called the Diagnostic Manual and it's considered sort of the Bible, if you will, of mental health diagnosis or mental illness diagnosis, and it has a long list of conditions and the symptoms and signs that you would anticipate to see in these individuals, or they would report more commonly what these individuals would report. Now we know that many individuals with Down syndrome are going to have less self-reportive symptoms. So a companion book was written called the Diagnostic Manual of Intellectual Disability, and this is the second edition. And more of the diagnostic criteria are around commonly observed behavior changes rather than self-report. And so self-report can still be an important issue, but in people with intellectual disabilities, Down syndrome specifically, what we view or what we see is very important. Perhaps it's sometimes even more important than what the person is able to share. Again, you want to get as much history as you can from the individual if they're able to provide it, but in some cases, the family or those around them are so key in providing some of what they're witnessing or what they're seeing. We're going to start with just run through just a few common mental illness situations, people with Down syndrome. So depression, and that can be persistent feelings of sadness or decreased interest in things that an individual previously enjoyed. So again, don't often get someone with Down syndrome to report that they're feeling sad. I mean, I do get that sometimes, but not commonly. That's not a common thing that people will say. But more commonly, family will notice, he or she's no longer interested in things that they previously enjoyed. They don't want to go there, or they don't want to do this activity or play this game, or whatever the case may be. So really, again, the observation is so important in helping with the diagnosis. Oops, backwards. So the symptoms we might see are depression or depressed or irritable mood, a loss of interest or pleasure in activities, as I mentioned, a weight loss or gain, a change in sleep patterns, slowing down of physical movement or restlessness. So it can actually be either or. Fatigue, feelings of worthlessness. Again, that's not something I would commonly have someone with Down syndrome tell me. So even if they're thinking that, it's not a history I commonly get from someone. Certainly decreased concentration, again, getting that history, but family observing that the person is no longer able to stick with something that they could do before readily. is certainly very helpful information. Recurrent thoughts of death, again, not something I would commonly hear from our patients. Sometimes there can be some psychotic features with extreme withdrawal, hallucinatory self-talk, etc. And sometimes there'll be inappropriate fears or avoidance of people or things. So really probably in our case, again, observing more avoidance rather than having someone relay or say that they have an inappropriate fears. And then particularly as things progress, sometimes people just have a very strong refusal to leave home. And so really they kind of get stuck at home, and that's not uncommon to see. And another common condition we see is anxiety. And it really is that anxiety that interferes with day-to-day life on a long-term basis. And so really from there's a general anxiety and stress of the day, but when it really begins to interfere with day-to-day life on a persistent basis, that really, then we're looking at potentially diagnosing an anxiety disorder. And again, feeling worried or anxious, again, not something I do hear it sometimes, but not often do not. You might see some mild self-injurious behaviors, some picking or some picking at sores or even just, slapping oneself or something like that. Again, fatigue is a common symptom of anxiety, difficulty sleeping, restlessness, again, difficulty concentrating, muscle tension. Again, not something that a lot of our folks will report, but you might witness that. And then irritability would be something that, again, would be commonly something observed, how that displays. And so depression, anxiety, again, are both probably more common in people with Down syndrome, as is obsessive compulsive disorder. And obsessive compulsive disorder is really very linked to anxiety. You will see that there's some real crossover in individuals between anxiety and obsessive compulsive disorder. So obsessions are persistent thoughts or thoughts that preoccupy the mind. So just something that we're just really stuck on, that's going through our mind over and over and over. And then compulsions are repetitive behaviors or acts that one feels compelled to perform. So again, in the same theme of we don't always get the individual able to, share what they're thinking. So we often don't get the obsession, the clear obsessional history. But the compulsions we see, families report or individuals report, the individual is kind of stuck on something and just is doing it repetitively. And in individuals without Down syndrome or an intellectual disability, oftentimes what one of the symptoms is they, for hand washing, for example, is a common one, and then we don't see that too much in Down syndrome, interestingly, but in the rest of the population, hand washing is something people just feel driven to do over and over and over, and some individuals will get very upset. They don't want to do it, and they know they want to go do something else, but they're upset because they have to do this over and over and over. Interestingly, many people with Down syndrome, they don't get so upset by the thoughts or the behaviors, by the repetition. They get more upset if the behaviors are blocked or prevented. And so if they have to move the pillow 20 times on the bed before they can leave in the morning, and you get in their way and just say, it's time to go, we can't do that 20 times, that may be when they get upset more than being upset about actually changing, moving the pillow. And really, so much more than you might just see with the groove, this really impairs function. So in some ways, it's almost like a rut compared to a groove. And so the person is just really stuck on doing something over and over and over, and they can't, they're having difficulty doing other things, not able to sleep, or not able to get to school, or not able to get to work, or not able to participate in recreational activities because they're so stuck on doing this thing over and over. And so that it really become a real challenge for not only the individual, but for the family when someone really gets stuck like that. And some of the other mental health issues we see are post-traumatic stress disorder. That's a challenging one because, we often present with symptoms of anxiety or depression. But oftentimes, again, we don't get the history of what the traumatic event was. And so the person may not be able to share what was the inciting event. And again, it's commonly thought, post-traumatic stress disorders, when there's a horrific car accident or a soldier coming home from war or, horrific hurricane or whatever the case may be. But again, this is in the eye of the beholder. So something that may not seem dramatic to you and I may be dramatic to the individual. And so we don't always get what that event was. Psychoses, little unclear if this is more or less common. I think it's probably overdiagnosed, but there does definitely seem to be some people that develop psychosis with hallucinations and whatnot. And then something called Down syndrome regression disorder, which is something that happens in younger people with Down syndrome, and they have a very significant loss of skills. There's I won't go into this further because that's a whole presentation all in itself. As similarly, I won't go into great detail about Alzheimer's disease, but that's another thing that happens in older people with Down syndrome who lose skills and oftentimes presents with other mental health challenges. And that one, unfortunately, is definitely more common in people with Down syndrome, the Alzheimer's. So how do we treat these? Certainly looking for how do you treat them, or how do you get treatment? And so certainly looking for a professional can help. Starting with your family physician or your internist. Certainly very important to look for the underlying medical or physical conditions, as I mentioned. A licensed clinical social worker or psychologist or other mental health provider can certainly be of assistance. And certainly someone that many people with Down syndrome, or at least some people with Down syndrome, cannot do talk therapy, but there's a lot of other ways to get the history and to work with individuals, even if verbal communication is limited. And some of those include art therapy, music therapy, animal-assisted therapy, all ways to help work with an individual to help them overcome the challenges they're facing. And then again, as people, as I mentioned, at least some people will not want to leave the house, and they really have lost skills. So it's very important not only to help them with the mental health, the mental illness, but also help them restore function that may have been lost. And so an occupational therapist can be real critical, real key in that. We're very fortunate to have an occupational therapist as well as a licensed clinic social worker in our office that really do help people as they've come through these challenges. Oops. So what are some general tips? Again, using visual memory. We know that we talked about how that being so strong. So using videos, modeling, family or others modeling the desired appropriate behavior. Once using the groove, help establish a routine, and then really having the individual, can able to do it repetitiously and with practice. And so that's a real, really use these common characteristics in a healthy way. And then the empathy radar, just providing positive reinforcement, really helping that person absorb the positivity around them to overcome perhaps the negativity that they absorbed from whatever the situation was. And so, really using these common characteristics in a very favorable light. And then certainly looking at physical health. Physical health is so important. Again, with the common things that can contribute to the decline of mental health. One of my favorite stories is many years ago, I was called, I was medical director of two 16-bed residential facilities, and I got a call from one of the staff that we'll call him Joe, had ripped the sink off the bathroom wall, and he's gone psychotic. We need to do something about it. And so I did an exam, and poor Joe had an ingrown toenail, and he was fiercely uncomfortable. And so that was the only way he was nonverbal, and that was the only way he could express his discomfort. So he did need a specialist, but it was not a psychiatrist. It was a podiatrist to address his ingrown toenail. So really looking for those things is so important, and looking and relooking and looking again, because sometimes things aren't always easily found. Sorry, I missed one line there. So really looking at healthy lifestyle is the other important piece. And so, good sleep, we have a lot of information on sleep hygiene, sleep routines really can be very important with regards to getting a good night's sleep, turning off the tablets and the TVs and the electronics, hopefully an hour or so before bed. Many of us don't do that, but that does help optimize sleep. Look at medications. Is there a medication the individual's on that might be disturbing sleep? Consider natural products. We've had good success with melatonin, valerian root, magnesium. I'm missing one. can't think of the other one. Oh, tryptophan. We've had good success using those, and there are some products that have combinations of those. And so, looking at a natural product to see if that might be helpful, and then if there's still ongoing problems, look at maybe prescription medications. And that's in addition to looking at sleep apnea, which is so common in people with Down syndrome, where the airway closes during the night while sleeping, and so that so important to consider assessing for sleep apnea. Sleep apnea can really contribute to mental illness, and so very important to consider that as a possibility. Healthy eating and good hydration, balanced meals, all the food groups, looking at portion sizes. Overeating can help people, contribute to people not feeling well. And then limiting the processed foods and the pop and the soda, which can really interfere with a person's general health and subsequently their mental health as well. And then regular physical activity. We know it's been studied in people without Down syndrome and not so much in people with Down syndrome, but I have no reason to suspect it's not the case. That physical activity has not only a big impact on our physical health, but our mental health as well. So, find out what works for the individual. And one of the common things I hear is, well, he doesn't play baseball anymore. He doesn't like to play baseball, or whatever the case may be. And when I was 45, I didn't like to play baseball so much either. There was other things that I would do as you get older. So again, this will change with time, just as it does with the rest of us. For most of our folks, making it fun and social is important. Incorporate it throughout the day. If there's a longer walk from the car, or if there's other ways to be active during the day, certainly we encourage that. And the other thing is, again, I think we're still learning, but physical activity outdoors really probably has some real advantages to indoor exercise, especially in the mental health arena. So getting outside and enjoying nature as part of the physical activity can be very important. Just in general, just turn off the TV and get moving, get outside and get going. Helping people manage stress. Again, I talked about stress being in the eye of the beholder. Look to see if you could find those triggers and practice strategies. We have a lot of information on our webpage about ways to manage stress. We have a nice video that the two women with Down syndrome did for us. It's great. I love it. But deep breathing, counting to 10, talking to family, coloring. 30 some years ago, I heard often, well, my son or daughter likes to color, but I'm not sure it's age appropriate. Well, people with Down syndrome were just ahead of the curve, because now it's well recognized that coloring is a stress reducer, and many adults color. So people with Down syndrome were just ahead of the time. And then just good listening to quiet music or relaxing music can be very very helpful for people with Down syndrome. Again, to recognize that there is a problem is so important, and before we can do anything about it. So really understanding that there is potential for stress, and then making sure that gets addressed. Counseling, again, talk therapy can be challenging for some individuals, but certainly using the common strategies and relaxation techniques and helping individuals learn coping strategies and problem solving and social skills. All these things, we have lots of information on our webpage about this, but all these things are very important with regards to helping people manage their stresses. And the picture on the bottom is a clip from the video of the two women with Down syndrome who talked about managing their stress. That's on our webpage. Even folks that don't really have a recognized sensory perception disorder of any kind can benefit from some of the sensory strategies. And Dr. Katie Frank, our OT, there's a lot of information available on our website about proprioceptive input, every activities like chores, compression of the muscles, using the muscles, joint compression, vibration, weighted objects, all can have benefits with regards to helping people feel better and then reduce their stress. And then with medications, when we do get the medications, generally our recommendation is to start low and go slow. Some individuals may need more than one medication. And for some individuals, we tried the other things and the non-medicinal approaches, and they're not responding well. And then you do put them on a medication, and it helps them actually then be more prepared or more ready to participate in the non-medicinal treatments. And so sometimes the medication will help the individual get to that point. And so then going back and trying those non-medicinal treatments that did not work the first time, but might help once the individual is a little more relaxed with the medication or a little more, physically and mentally able to participate in those non-medicinal strategies. So it's not one or the other. It's both. In some individuals, and some individuals, it's just when you add that when the non-medicinal treatments don't work, and others, depending on the condition, it's clear that they're going to need some medication to participate in the non-medicinal treatments. And the medications, maybe, I'm not going to go into great detail, but antidepressants, benzodiazepines, like lorazepam or diazepam, some of the non-benzodiazepine anxiolytics, the buspirone, and some of the mood stabilizers, which are seizure medications, and then sometimes antipsychotics as well are all potentially used depending on the individual and the condition. So I've got just a few more minutes. I just want to run through a few case examples and then open it up for your case examples, if you will, for your questions. So an 18-year-old man was putting his head on his desk at school and not participating in class. And the teachers and parents were concerned that he was depressed. So he was sent to us to be evaluated. And part of the, again, looking at physical issues and part of the physical exam, I noticed that his deep tendon reflexes were increased. And so we got a lateral cervical spine x-ray, and he had atlantoaxial subluxation, which is where the first vertebrae slips on the second, which is more common in people with Down syndrome and can cause spinal cord compression. And so he was not putting on his head on the desk because he was depressed. He was putting on his head on the desk because he was having a hard time holding up his head because he had this very severe abnormality in his the spine in his neck. And so his treatment was not antidepressants. His treatment was surgery to correct his neck problem. So again, that sounds almost unbelievable, but that's actually a true story. And so that is you really have to look for these underlying physical causes that could be contributing. 34-year-old woman had increased self-talk. She had some distorted thought processes that involved intertwining real-world events with TV shows and movies, and she had lost interest in activities she previously enjoyed. We learned that her symptoms had started after her sister left college, and she started seeing a counselor, and they were having a hard time working through all these things. And so we participated in her care and started antidepressants, and she had some improvement, but she had really gotten so sort of lost in this the not real world. We also ended up treating with an antipsychotic, and then as she improved, she needed what I call a safe reintroduction or a gradual reintroduction to activities. And so really, once people feel well, to suddenly, have them rush right into activities can be challenging for them. And so oftentimes it takes sort of a gradual, slow reintroduction back into activities. So another one is a 22-year-old man with Down syndrome who aged out of school. He started to gain weight and had a disagreeable mood and was having difficulty sleeping. So again, we did a good history and physical exam, and the question was whether this was just kind of an adjustment reaction to aging out of school or whether this was true depression. He had labs and a sleep study, and there was no sleep apnea. Really helped him establish a new routine with daily activities now that he was out of school. And that did seem to help, but he was still just having some difficulty, moving forward. And so he ended up, we used the bupropion, Wellbutrin for depression, and then a little trazodone to help him sleep. And that really got him back on track. We got him back off the medications, and he was off and running. And that's not an uncommon scenario with the challenges of leaving school, unfortunately. And then lastly, I'm just going to go through this one. A 43-year-old woman living in a residential facility had become mildly aggressive. Again, she lived in this group home with several other women. And the behavior occurred after dinner during chore time. And so they had a system at the home where after dinner chores rotated amongst the housemates. So for example, there were 5 chores to do, and the 5 nights of the week, during the week, they each were assigned one of the chores. So on Monday you swept, on Tuesday you emptied the dishwasher, Wednesday you did this. And so that was all shared by the 5. She liked to sweep. If she wasn't assigned to sweep, she took the broom from her housemate. And so that they insisted that she followed this routine, and she was not able to do that. And so we examined her and talked to the folks, and decided that no one else in the house really cared if they swept. She liked to sweep. She was the best sweeper in the world. Frankly, just let her sweep, and that was really the solution to the problem. So I always joke that they were concerned that she had obsessive compulsive disorder, and I told them, yes, someone has obsessive compulsive disorder, but it's not her. It's the necessity to make her sweep, make her switch around and have others sweep was really the challenge. And so really just no medications involved, just changing around the schedule. So to wrap up, and then still have some time for questions. So typically common behavioral characteristics are not necessarily a sign of mental illness. If there's a change like self-talk or the groove, that certainly can be a sign of mental illness, but in and of itself, we don't think that those are. Changes in behavior should prompt an investigation into the cause. And again, looking at the social issues, the physical issues, as well as mental health issues are all important to look at. And again, because these three are so interrelated, particularly in people with Down syndrome, likely because of the communication issue. And while some mental health problems are more common in people with Down syndrome, there are many treatment approaches that can be used to help individuals recover. And so many people with Down syndrome can be treated successfully for their mental health or mental illness problems. Again, lots of information. I appreciate that. Dr. McGuire and I published our second edition of our mental wellness book for adults with Down syndrome in it was 2021 or two, I forget, 21, I think. And then unfortunately, Woodbine House, the publisher, went out of business the next year. And so after looking at it, we've decided to make this available free online. It's available as a PDF on our webpage. And recently, the Matthew Foundation and Dr. Flores from Spain were kind enough to work with us to translate it into Spanish. So it's available in Spanish as well. Again, free on our webpage. If your provider is having a challenge with addressing some of the health issues for your son or daughter, or for a brother, whoever, sister, whoever it may be, the Down Syndrome Medical Interest Group has something called, we have lots of resources, including something called Project ECHO. This is not for families, this is for providers, but a provider, a therapist or a physician or whoever can anonymously present the case to the group and the group via a Zoom. And then the group provides feedback, and then the provider can go home and treat that individual at home themselves. And so that's a nice service, no charge, and available through the Down Syndrome Medical Interest Group. We have lots of articles that we talked about through the course of this presentation that you can find on the slide. And this is I can never remember what those little things are called, the little squares, but you can take pictures of those and find our resource library, our Facebook page, and our email newsletter. If you want to sign up for that, you're welcome to, and use those for more information.